Hello, everyone. Good afternoon. I'm Dr. Azai Rosman from Malaysia, and it is an honor and a privilege for me to chair this session, co-chair with our colleagues from Singapore and my colleague from Malaysia, Dr. Asiranga, who is the deputy head of the Department of Cardiology in Serdang, as well as the head of services in Malaysia. So today's session is courtesy of Terumo, and it's indeed an honor for us to have such a distinguished panel of speakers as well as panelists to address some of the vexing issues with high bleeding risk and short DAPT treatment. Now, this is the first of, we hope, many series of master classes. This particular master class is about the DAPT, and of course, it will seek to address some of the issues which have come up because of the recent trials, and I'm glad to say that the trials have been positive, and of course, to set this against some of the previous trials that have made their way into our practice. So today's sessions in a nutshell would be to make that transition between evidence to clinical practice. Now, it's easier said than done because as far as the APT and high bleeding risks are concerned, there are so many moving parts really. And we've engineered this in such a way that Jack and myself, so that it becomes a bit of a interactive session. And so this part that we are having, Jack and myself, will be the first of two parts. Jack, can I hand this over to you to make the initial introductions about our panelists and our speakers?
Thanks, Azari. My name is Jack Tan from the National Heart Centre Singapore. I'm very happy to co-moderate, co-chair this session with Azari. Anyways, a roundtable format. We have two parts to this afternoon. Part one, which we're doing with Azari and our friends from Malaysia and Philippines, is on why do we need to change the DAPT practice. It's going to be a roundtable discussive format, so please feel free to voice all your comments and provide your questions as well. Part two will be helmed by Professor Tan Hui Chim, who is going to talk about how do we change our DAPT practice. So within the next hour, we're going to have a very discussive session. But before we do, I'd like to get Azari to introduce the rest of the Malaysian panelists first.
Right, thanks, Jack. This is, of course, a distinguished group of people. I mentioned earlier on, they are at the forefront of clinical management. The first is Dr. Kamraj Selvaraj. He is the head of cath lab facilities at Serdang Hospital, a very large hospital in Kuala Lumpur. And of course, you've heard earlier on, Dr. Asiranga on my right. He's the deputy head as well as head of services. And he's also practicing at Serdang Hospital to actually deal with many of the government patients. Jack, over to you for the Philippines group.
Now go to Nick Cruz, and Nick will help us introduce our Filipino colleagues as well. Nick, please.
Good afternoon. Hi, Jack. Nice to see you, and Nick. Dr. Rosman as well.
Too. Yeah.
Yes. I'm Dr. Nick Cruz. I'm a private practitioner practically. I work in a private hospital here in the Philippines as an interventional cardiologist. I'm honored to be here on the stage with two distinguished interventional cardiologists. One is the president of the Philippine Society of Cardiac Catheterization, Dr. Eduardo Tinhay. And to my right is one of the pillars of interventional cardiology training, at least for training here in the Philippines. And he practices in the biggest heart center in the country, the Philippine Heart Center, Dr. Ronald Estacio.
Thanks,
Thanks,
Nick.
Jack.
Yeah, thanks. Good to see you guys, even though virtually. And let's jump straight into the discussion, shall we, Azari?
Yeah, why not?
For this topic of why do we need to change that practice, we'll go to Malaysia first. Maybe Silvaraj would like to answer and take this question. Currently, in the landscape of guidelines, are you happy with the DAPT guidelines for use from ESC or ACC or your own national guidelines? Where do you think are the evidence gaps, and do you apply this to your clinical practice? Silvaraj, please.
Thanks, Jack. Once again, I'd like to also record my thanks to Terumo for having me here, and nice to see all of you all again, even as you said, though it's virtually. So yes, guidelines. We've got a lot of guidelines: the European guidelines, American guidelines, and then we've also got our own Malaysian guidelines. Actually, nothing much has changed. I mean, we started off with the 1 year thing, and then now, uh, of course, the only big changes has been the addition of OACs and NOACs, etc., into our guidelines. So in Malaysia, we are still following 1 year DAPT for ACS patients. And if it's with NOAC or AC, we go with 1 month triple therapy and then followed by 11 months dual, and then after that, just put them on the NOAC. So the reason we do this, of course, we know is basically uh, the bleeding tendencies of these patients, especially when they're on double antiplatelets. We have, of course, aspirin plus either clopidogrel or ticagrelor. We don't use prasugrel here, and in a lot of cases that we have used, we found a much higher level of bleeding. So we are more comfortable using clopidogrel and ticagrelor post PCI. This is the basics. Now, of course, over these past few years with Leaders Free and Onyx One and now Master Dep, of course, they're talking now about reducing the DAPT to 1 month. So I think before I even go into that, I would like to say that it is not a necessity to stop this DAPT. I think all these studies were there to just prove that it is still safe in certain cases where the patient has got high bleeding risk, whether the patient starts to bleed, etc., on DAPT, that you can stop the DAPT after 1 month safely. However, it basically depends case to case. So in my practice, that's what I do. We have had cases where patient bled, upper GI bleed, high risk patients, even pregnant women that we had stented that we needed to stop the DAPT after 1 month. So it's good to know that we have that option and that choice now. Of course, then there's the other group, that's going on, for DAPT or at least SAPT, for example, ticagrelor 60 mg for after 12 months, up to 26 months, 28 months. That I'm not sure because at the moment we are trying to cut down the usage of DAPT as much as possible instead of prolonging it. So yeah, that's basically the practice we do in Malaysia. When it comes to OACs, as I said, like it's 1 month triple and then 11 months dual, and then after that, you just go on with the OAC or the NOAC.
Thanks,
That's it, Jack.
Silraj. Yeah, thanks, Silraj, for those comments. Maybe now move to Philippines. Is it the practice in the Philippines, and are you guys using also the same flowchart algorithm from ESC 2019 as well? Maybe Nick Cruz can take this question.
Thanks for that question, Jack. Actually, we use the same guidelines. It's more of a hybrid, actually, following the American guidelines and then also the ESC guidelines. And this is basically whichever is the latest. I would say, and I hope I can speak for these two gentlemen with me today, that in the Philippines, we are quite compliant with guidelines, particularly with regards to dual antiplatelet therapy for both ACS patients and stable ischemic heart disease. There are a few, however, that I've observed that still follow the old guidelines of extending the dual antiplatelet therapy for ischemic heart disease that are stable up to 12 months and beyond. And I guess these are in patients who are at not so high bleeding risk, because everyone actually is high bleeding risk if you will really think about it. So it's a hybrid of ESC and AHA or SKY guidelines that we actually practice here in the Philippines. The recent focus on high bleeding risk is something that is gaining attention locally here also. And we used to talk about extending dual antiplatelet therapy, the benefits of prolonging antiplatelet therapy beyond 1 year because of the high ischemic risk. But it is just recently, and thanks to all these new trials, that we now are beginning to focus on patients who are at high bleeding risk. Of course, we all need to be aware that between bleeding risk, which can kill also, and the risk of ischemia or ischemic risk, the bleeding risk actually seems to be a bigger problem compared to ischemic risks. Again, we're happy that now we have new studies, not guidelines yet, but new studies that tell us that there are situations when we can limit our dual antiplatelet therapy to 1 month in a special subset of patients if the need would arise. Thanks. Thank you.
Thanks, Nick, for that perspective. Can I just go back to Malaysia? Perhaps Asri can take this one, though. The crux of the guideline is assessment of bleeding risk. In Malaysia, are you guys also using the ARC bleeding risk consensus as a gauge for bleeding risk, Asri?
Hi, Jack, thank you. And thanks to Terumo for giving me the opportunity to speak at this platform. On my daily basis, when I see my PCI patients, I think there are three groups of patients who will benefit from short DAPT, short dual antiplatelet therapy. I think one group is what we talk about, HBR patients. And I use, like what Jack Tan mentioned, the ARC HBR criteria, major and minor. So one major, two minor. So more than almost 70% of my patients fall into this group where age more than 75, end-stage renal failure or CKD, anemic patients. Usually the CKD patients come with anemia, and those with on oral anticoagulation, and rarely those with malignancy and so on. So a large group, 70%, fall into this group. I rarely use precise DAPT score. You need a smartphone to calculate 25 and more. But there are another two groups of patients I come across in Malaysia, especially one group are those prison inmates, illegal immigrants, those with mentally challenged patients where compliance might be an issue. And the third group is those who are going for surgery. So they're not addressed in these guidelines or anticipated surgery. So I would like to use a short DAPT in this group of patients. But so when you talk about HBR, for me, there's no complex calculation, but basically most of them, I would actually go for just the ARC criteria, and that's where I make my assessment and so on. Yeah, thank you.
Thanks, Asri. So I quickly like to just sum up the first part about guidelines. I think guidelines are just a guide. I think what is clear that the guidelines have been keep changing based on new trials and evidence to lengthen and shorten based on ischemic balancing bleeding risk. In the ESC guidelines, what has remained quite consistent is that for the clinical scenario of ACS, they are still recommending up to 12 months of DAPT if the patient can tolerate. And in the high ischemic risk threshold, low bleeding risk assessment group, you can consider extending it beyond 12 months, the DAPT regime. Whether you down titrate to prolonged extended DAPT with clopidogrel, ticagrelor, or prasugrel is up to your clinical assessment. So Asri is going to lead the discussion on high bleeding risk, but that's truly the crux of where we are getting at, because the ESC guideline endorses the ARC bleeding risk criteria is not too bad as a binary. Just to refresh people's assessment, it hits high bleeding risk if the annual bleeding risk is BUG3 or 5 or more than 4%, or more than 1% intracranial bleed at 1 year. If you meet that criteria of having this risk, then you are high bleeding risk. So if you're high bleeding risk, actually the ESC guideline says that the very high bleeding risk, you can truncate the DAPT down to a month, and anything in between based on ischemic and bleeding risk. And the preferred agent for truncation or use of DAPT is clopidogrel. And if you do need to drop, they do indicate a preference of dropping aspirin rather than P2Y12. So continue P2Y12, drop the aspirin. The ESC guidelines then also had a refresher to say that if the patient has tolerated at least 3 months of aspirin ticagrelor, you can follow the 12-light regime for the low bleeding risk group to then have ticagrelor monotherapy for the seemingly complex PCI but low bleeding risk. What we like, and we'll probably discuss in how to change practice later on, is the new Master DAPT program that was very good. The first trial that shows that there's no price to pay for truncating DAPT therapy down to a month versus 12 months in terms of ischemic and bleeding risk for white subset of all-comer patients. We'll discuss that further, but now I'd like to move back to Azari to lead the discussion on the next question. Azari, please.
Thanks, Jack. So basically, what we're trying to make the shift is perhaps trying to consider when we weigh ischemic risk and thrombotic risk, what is the benefits and or the gain, the net gain from using an abbreviated antiplatelet regime. So as you know, the Master DAPT, which was announced last year, was really a landmark trial. It was a very well designed trial. Many of you have, but that has actually been pivotal because it is probably the only trial that has actually used a proper scoring system, and this is the precise DAPT. And I admit many of us don't really use that yet, but I'm trying to make the case for the increased use of this score, because now it's available on your smartphones, and I think in selected groups of individuals, it will be useful to look at the risk and consider, for example, whether or not you should abbreviate your treatment. So with that, I think the fact that we now have the Master DAP trial and whether we should actually factor that into our decision-making process, because it's a well-designed trial, because this actually compares the short as well as the standard as well as abbreviated therapy. Maybe I can ask Dr. Asri, do you think this Master DAPT trial will actually make a difference in your management in the future? And more importantly, of course, I suppose, as to whether or not we should be formally applying the risk score in some of our patients.
Yeah, thank you, Dr. Azari. Very good question, very lengthy question. I think prior to this, we had a few other trials regarding, the LEADERS trial and then the Onyx 1 trial, which to put in perspective what stands with short depth. And I think the Master depth trial was the largest of the trials, and I think it actually validated your precise depth score more. I think prior to this, most of the trials, there was a very loose definition of HBR. And until the ARC criteria came in, it's still not a score, but it's easier to calculate. I suppose with smartphones and so on, you can actually, incorporate it into your practice. The other thing Jack Tan mentioned just now about the BARC criteria and so on, just for the information audience, BARC is actually not a predictor for bleeding. It's like you assess once the bleeding occurs. So don't get confused. So you still need something like precise depth. So bleeding occurs, then BARC, you got TIMI score and things like that. So that's something very important to ascertain here. The thing about short depth is, in my practice, I will still give for elective patients 6 months and ACS 12 months. But with this Master DAPT, I have added confidence that I can stop the treatment if necessary within 1 month, if the patient starts to bleed and so on. So I think it will enhance our repertoire of stents we use and so on, and more confident in managing such patients. And actually you can tell the patient up front, okay, this is what your bleeding risk will be. On the other hand, there are certain patients where you would want to continue the depth longer, or even, careful about it, those with the complex bifurcation stenting, previous stent thrombosis, long stents, more than 60 millimeters, more than 3 stents use CTO cases and so on. So there's a list of these patients we have to be careful about. Yeah, thank you.
Thanks, Asri. So you've actually mentioned two broad scopes. One is the device-related factor, which makes you decide one regime or the other. The other is, of course, the regime, the medication itself. And on top of that, you have the various characteristics, the other moving parts such as lesion characteristics, patient characteristics, and risk, and so on. And because there are so many things that actually need to be factored in, and because bleeding is actually a continuum between low bleeding risk to highest bleeding risk, this is where we need to remain dynamic. And I think the core message is that it should be individualized. So on that note, I think we'd like to find out what our Filipino colleagues have to say in regards to this very interesting and groundbreaking study. Has that changed your management, or will that change your management? So perhaps I can ask Dr. Eustacio for his comments in regards to what they are doing in the Philippines.
Salamat Tengah Hari to my Malaysian friends. Good afternoon. The practice of using DAPT, well, I still echo Dr. Kamaraj and Dr. Asri. I still go for a 12 months DAPT. the master DAPT trial would gave us a glimpse that we may be able, or it is safe to stop the DAPT after 1 month in patients who have high bleeding risk. And as Dr. Astri said, it's still the thrombotic risk, especially for patients who you've done CTO, bifurcation, left main bifurcation. These are patients you have to look into the thrombotic risk. So even if, for me, even if there is in the calculator, there's a high bleeding risk tendency, I would still go with a dual antiplatelet, and then just assess the patient, maybe push it to 12 months. And if the patient bleeds, then I know it's safe to stop the APT after 1 month. And then maybe after the bleeding stops, then I would not totally stop my antiplatelet, but I would de-escalate it to a single antiplatelet therapy, maybe for 12 months.
Right. So you made the very important point that you have to adjust the doses as you go along. Now, do you think that you might move on to use a proper scoring system, perhaps in your management of these very high risk groups of individuals, or do you just use a clinical assessment to make you to help you decide? Should we advocate be
the
advocating a
calculator
precise
that
DAPT score?
it's there to help me profile my patient, who and who's not going to bleed, but to change my practice of all patients with high bleeding tendencies, just to stop it at 1 month, especially if I did a bifurcation or I opened up a CTO. I would not push for that, but I would just observe, do my dual antiplatelet, observe it. If the bleeding occurs after 1 month, then I know I can stop it safely, because most of the trial, even if the master's DAPT trial only showed non-inferiority to 3 months dual antiplatelet. So it just tells us that it's safe to stop. And then when you are able to control the bleeding, maybe just de-escalate now your antiplatelet to a single antiplatelet therapy. So it's still, as Dr. Astri would say, it's still a case-to-case basis and a patient-to-patient basis. So it's not, for me, it's not going to encompass in total the whole patients that I do PCI on.
Right. It seems you're more concerned about thrombotic risk rather than a bleeding risk, because that's probably something that you can manage, and you can mitigate in some groups of individuals this bleeding risk. So I think if I can just summarize the conclusions from this assessment of high bleeding risk, I think the scores are helpful. They are relatively new in our clinical practice. The most precise is your precise DAPT. And I think if we can, we may consider using it for our patients, but if we're not and we're comfortable with the clinical assessment of the risk, then we might opt to actually continue as long as possible as per the guidelines. However, if there is a need to terminate, we have that comfort of knowing that we can actually stop it to within 1 month. This is the most important point. And of course, the fact that the Master DAPT is, of course, device specific in terms of the trial in using this particular type of stent. But at the same time, you have that comfort that if you do need to reduce, there is a safety margin in terms of bleeding. Now, there is no increase in terms of events compared to your usual treatment. So I think this is a big change, game changer in terms of our management. We have a comfort level of knowing that when we're comparing one versus the other regime, there is, of course, a benefit to be obtained. So Jack, over to you to the other section now on the OAC scenario.
Thanks, Zari. Before I jump in, maybe I also like to give some of my comments about scoring and HPR. Regards to the scores, I think the thing to take note is that the precise depth actually is upfront scoring, where you look at the ischemic versus bleeding risk, and it gives you an upfront idea whether it should be extended or short. What I would like to then talk about is that a lot of these scores are not validated in our Asian cohort. So we must take it with some pinch of salt in terms of practice and variation in drugs. and the generation of stents used in those studies at reference was pretty old. The other part was that the HBR risk criteria really is the crux of it, and I think the ARC bleeding risk criteria at least give you a hint of whether this is likely to be a high bleeding risk or not. And in my mind, most of our interventional practice nowadays, most patients are HBR or HBR2B, so the practice should evolve to saying that we should be careful about thinking of this as going to be a HBR type of case once it fulfills either a BARC major or 2 minor criteria, just to be a bit cautious. Although it doesn't change how you do your intervention, but you need to do it even better for this group of patients. If you do it routinely for all, I think it's less of an issue. So I think now the next subgroup that we really have to pay a lot of attention to is a subgroup requiring some form of oral anticoagulant. And Kamraj talked about it a little bit just now, but can Kamraj again refresh us? What do you think is an evidence gap? Because the ESC guidelines says that in the high bleeding risk, you can just use 1 week and stop it before they get discharged. And looks like everyone's practice here is 1 month or triple therapy. So can you tell me the gap in terms of duration as well as the dosing of the OAC? Kamraj, please.
Sure. Thanks, Jack. As I said just now, basically it's 1 month triple therapy, and then followed by 11 months dual, and then we just go on with the NOAC or the OAC. So the reason is again trying to balance out the thrombotic and the bleeding. I don't know. I'm still not very comfortable stopping it after 1 week. Because as I said, for the thrombotic risk. Of course, now we got the NOACs, so they are easier to manage, easier to handle. You don't have to worry so much about repeat INRs going haywire, etc., patient bleeding, things like that. Of course, with NOAC we got other problems because reversal is an issue, except with dabigatran. However, dabigatran, we can't use it in patients with end stage or very low GFR. So in that case, you need apixaban or rivaroxaban. But the problem with those is that there are no official, no proper. They are, but they're very expensive reversal agents. So that is a bit of an issue. But I think in most of our cases for AF, etc., we've started patients on NOAC for ease of patient as well as ease of our management and services. So that is the way I go. It's still 1 month, but again, depending on the bleeding, whether the patient develops any form of bleeding, etc., that requires stoppage of the DAPT.
Thanks, Kamraj, for those comments again. Eduardo, maybe in the Philippines, maybe you can give us some tips and tricks about how to mitigate the risk, ischemic and bleeding risk for this group of patients who require triple therapy. Eduardo, please.
Hi, Prof. Tan. Hi to our Singaporean and Malaysian colleagues. I cannot say that there's a large gap in the triple therapy population post PCI. But I think North American and European guidelines, some of them recommend to stop antiplatelet therapy after 6 months. And as you can see, this is based largely on consensus and earlier data. And with the current master DAPT study, I think there's no clear benefit in doing so. And also, there's a high non-adherence to this. Most interventional cardiologists are quite reluctant to remove antiplatelet therapy even after 6 months. So as you can see, there's lack of power and high non-adherence. And also, with all this triple therapy data coming out, we can see that the shorter the triple therapy duration is, there's less bleeding. And at the same time, there's a higher rate of stent thrombosis in the population wherein you stop aspirin and there's numerically high or increase in those subsets. So I think not crystal clear on the part, Prof. Tan, of maybe after 6 months, do we remove the antiplatelet therapy together with the NOAC, or maybe what antiplatelet therapy to pair with the NOAC? after 6 months. That's all, Prof. Tan. Thanks.
Thanks for those comments, Eduardo. So maybe I just quickly provide my perspective. Thanks, Kamaraj, the APSC guidelines actually also endorse 1 month of triple therapy for both ACS and stable patients who need OAC. Recognizing that in Asia Pac, there's a wide variance of practice. Not everyone is like East Asia, everyone gets intravascular imaging and tip-top PCI. So I think 1 month of triple therapy is probably safer. The guidelines actually advise that you don't dose adjust down your NOAC dose because we're not too sure whether it reduces efficacy or stroke prevention if you just drop it. The guidelines say full dose, but reduce the duration of triple therapy. And you can still reduce it based on the balance of ischemic versus bleeding risk. In your ACS subgroup, we say that try to maybe go to 3 months if the bleeding risk is not too high for triple therapy before truncating. The guidelines is actually quite clear that after 1 year, OAC alone without antiplatelet is pretty safe for most patients, whether warfarin or NOAC. That's quite certain. Anything below 1 year, we're not certain, so you have to gauge on an individual basis. The ESC guideline also clarified that you can use OAC together with the third generation tirapyridine like ticagrelor, but you cannot combine it with aspirin. So you can use dual therapy with ticagrelor with OAC, but not with aspirin. Eduardo made a good point in Augustus trial. When they dropped the aspirin very early, there was numerically higher rates of stent thrombosis. So we had to be very cautious that a freshly implanted stent, just on dual therapy alone, whether it's pretty safe or not, as an upfront strategy, I'm also not too certain. So the take-home message for OAC is that do a perfect intervention. Do an intervention only when you have to do an intervention. If you don't have to do an intervention, don't put in any metal or put in too much metal. If you have to put it in, it must be imaging guided. To reduce your bleeding risk, you have to truncate the duration of triple therapy to as short as possible. In Asia Pac, we endorse 1 month. ACS can go up to 3 months. After 1 year, drop all the antiplatelet, which is pretty safe. So back to you, Azari, for the next segment. Thanks.
This is a problematic area because these are involving ACS individuals, and I think patients have been included in the trials, especially the recent DAPT trial. They have had ACS individuals. So these groups of individuals really have a higher thrombotic risk compared to an ischemic risk, compared to a bleeding risk. So I think, Dr. Nicholas, what is your view in regards to your ACS patients and your decision with regards to antiplatelet therapy? Do you have any views on that?
Thank you for that question. The biggest problem we have with ACS patients is that we cannot choose which ones we can get. So they may be high bleeding risk, they may be moderate bleeding risk, or even probably low bleeding risk if such a thing exists. However, we have to realize that all patients can potentially be high bleeding risk patients. The problem is ACS patients are high ischemic or thrombotic risk patients. So when we deal with ACS patients, and you have to deal with the high bleeding risk patients, particularly patients on oral anticoagulants, those who have malignancies perhaps, those who have anemia, those who have CKD, and these are patients who are candidates for ACS. You may have to think of what to do with these patients in terms of these patients potentially being high bleeding risk patients in the future. The status of patients with regards to bleeding risks, it's very fluid. You may be moderate bleeding risk today, but tomorrow or a month from now, you become high bleeding risk. So it's very important that you prepare your patients, ACS patients in particular, to consider them as potential high bleeding risk, and then prepare these patients for possible abbreviation of their dual antiplatelet therapy. So I think there are 3 basic groupings here. One is patient profile, which we have discussed already. Patient profile being high risk for bleeding and being high thrombotic risk. Number 2 probably will be lesion profile. What kind of lesion you are dealing with? Is this a left main? Is this a bifurcation, even if it's ACS? Is this something that would require multiple stenting? So this is very important, and Jack has mentioned already the importance of imaging in these patients. You have to do your job really well, and particularly in our local setting here in the Philippines, where if we don't do a good job and these patients come back, for instance, for stent failure, we have very limited options. We do not have intravascular lithotripsy here. We do not have laser. We're just limited with balloons and probably practically nothing else except rotablation, which you may not do if you do a bad job after stenting. So these are very important things to consider. The third one that I think is really also important is aside from doing imaging when you do ACS patients, is also to choose the type of stent that would back you up in terms of the need for shortening or abbreviating the APT. And there's several stents in the market now, and I'm not sure whether it's a class effect of new generation stents, but at least there are stents that have been used in particular or specific studies that say that truncating it or abbreviating your dual antiplatelet therapy to 1 month if the need arises in ACS patients may be possible and safe.
Right. Thank you, Nicholas, for that comment. I'm also wondering. You raised an important point earlier on that your basic assumption is that that patient will probably potentially have a higher bleeding risk, and that, of course, the other point that I caught on was the fact that you had a choice of device based on the trials that were relevant. So, I'd like to ask Dr. Asri, what is your view in regards to having an ACS patient, and all things considered, lesions and everything? Which is a more important point that you are concerned about? Is it thrombotic risk or bleeding risk? On balance, sort of, given the criteria available.
Thank you, Azari. I think I wholeheartedly agree with what Dr. Nicholas mentioned just now. We cannot choose our patients. And I know in some countries, when the patient comes in, especially in primary PCI setting, you have no way or no time to assess the bleeding risk and so on, and they end up putting in the past bare metals. And nowadays, I think automatically you rather choose a stent with short depth is available. I think when you are pressed for time and so on, I think it's more prudent to do that. And of course, when we do the procedure, we are more worried about thrombotic risk during the procedure and so on. I think one way is doing radial, and another thing which is echoed by Dr. Jack Tan and also Dr. Nicholas about imaging. I think that's very important to get it right. So when in doubt and so on, I think I would go for those with the stents with backup evidence for short depth, yes.
So in other words, as you made the point that the device also matters in regards to the duration of the APT.
Yes.
Yeah. Okay, thank you very much. So in other words, we've made the point that earlier on in ACS patients, you have a balance of thrombotic as well as bleeding risk. And the fact, given that our distinguished panelists have said, given the fact that there's good data available for stents for short duration DAPT, we would factor that into our decision-making process. And the second thing is, of course, I think the sensible advice that our colleague mentioned earlier on, that there is an assumption that you should consider all patients potentially at high bleeding risk, and that gives you a better footing in terms of managing. So the simple, at risk of oversimplifying, I suppose the simple default is probably to try and consider as short a duration a DAPT as possible, even though it is an ACS individual, of course, given exceptions to the rule, but as short as possible, because there are now data as well as devices available for us to do that. So I think that's a sensible sort of approach that we can take home. Okay, so I think, Jack, over to you to have a look at your thrombotic risks.
Thanks, Zari. So now maybe we focus on the group of patients that has both high ischemic and high bleeding risk. I would like to get the opinion from Ronald and Dr. Tin Hay as well. In the group of patients who has true high ischemic risk as well as high bleeding risk, which is your greater concern? Is it the ischemic risk or is it the bleeding risk? Ronald, please.
If you talk of a patient having both, for me, I would go for the thrombotic patient. I would consider more the thrombotic risk in rather than the bleeding risk if you're going to do your intervention here. As what I've stated, if the patient has both, then you still have to put your DAPT, and you now know that you can terminate it in a short period of time. And we all know there are stents now that can tolerate a short course of DAPT. I think if you have both, it's so difficult to separate one from the other. but you have to consider a high thrombotic risk and a high bleeding risk. So what I would do is still put my dual antiplatelet, do my intervention very well, and choose a stent that can tolerate a short DAPT. But in the cath lab, usually I always think of a patient in ACS always having a high thrombotic risk. So I think in mind, you always choose a stent that can tolerate, or a stents that will be able to handle a short DAPT duration, and just manage the bleeding risk of the patient very carefully.
Thanks, Ronald. Dr. Tin Hui, is it the same for you as well?
Hi, Prof. Tan. I think Dr. Nick Cruz reiterated earlier, he hit it right between the eyes when he said we cannot really choose our battles or choose our patients. So I think, with due respect to my colleague, Dr. Stasio, I think the most problematic in the cath lab and in our practice will be those high bleeding risks. Because when we talk about high bleeding risks, based on landmark trials before, the CB safety outcomes, the bleeding trials, we can see that if your patient suffered a major bleeding, intraperitoneal hemorrhage, etc., you will obviate the need, or maybe you cannot give your anti-thrombotic and anti-ischemic therapy or antiplatelet therapy. And that led to several mortalities and morbidities. So if you counter these patients, you don't have anything to give and anything to throw. So I have to stick with the problematic one, the high bleeding risk patients. Thank you, Prof. Tan.
Thanks. That's quite interesting counterpoint. So we have half-half, high ischemic versus high thrombotic. Maybe I quickly summarize my perspective for today's first segment of why there's a need to change our DAPT practice. Let me just go back to a little bit of a historical update. I think when I was first registrar recruiting the Cypher Texas trials, we were saying 1 month is good enough for DAPT for a bare metal stent in a stable indication. And 3 months was okay for the trial recruitment for Cypher, and 6 months for Texas. And then you all knew what happened about a decade plus ago with the ESC publication, saying you got late stent thrombosis with the first generation stents, like Cypher in particular. So arbitrarily, people were very worried about patient death from stent thrombosis, and arbitrarily the DAPT duration became 1 year, even for stable patients. What has confused people is that for the ACS indication, the 1 month DAPT is very evidence-based and strong. Sorry, the 1 year DAPT is very strong. But for the stable indication, stretching it to 1 year just because you put in a drug-eluting stent is very arbitrary, not evidence-based. But be that as it may, it became the standard guidelines. If you put in a DES, 12 months of DAPT, regardless of indication. So what has happened now is that we are very appreciative of all this series of trials, starting from the leaders free from biosensors, saying that at least a 1 month DAPT is equivalent between a DES and a bare metal stent. Both still have high bleeding risk and high ischemic risk. And the event rate is still 7 to 10%. But it's quite certain that it's no worse than the bare metal stent in dropping antiplatelet agent to just go single, comparing to a BMS. Then you have seniors, you have Onyx 1, you have Zymes 28, and all these trials were just comparing that is equivalent to the other stent or the other strategy, whether against another DES, against DEB, to drop the DAPT to just 1 month. But it doesn't tell you the strategy for addressing 1 versus 12 months of DAPT. So we're very appreciative of the Master DAPT trial coming out to say that for all comers group, there's very little price to pay to drop the DAPT to 1 month in this all comers, whether it's stable or unstable. And he also addresses the stent qualification part. So I think it's still moving around. There is some need to titrate the practice. In the subgroup of patients with high thrombotic and high ischemic risk, please, both are correct. So both Ronald and Tin Hui are correct. If you have a high ischemic risk patient, you don't address the ischemia, they're going to die. The high bleeding risk gives you a background of what you must do to mitigate the bleeding risk. So when you go in, do your imaging, do as little matter as possible, do the required and get out. For the high thrombotic side, you cannot just extend it just because they are high ischemic risk. You have to truncate the DAPT to as short as possible. And in this day and age, we know that a lot of the stents has indication for 1 month DAPT. So use those evidence to guide your practice in terms of truncation or DAPT to reduce the bleeding. and to adjudicate how you do the intervention, even in a complex case, to get the patient over this journey of ACS. But I think there is some confusion there, and we'll continue to address all this concern in section 2. So, Azari, you have any comments or questions from the audience at this juncture?
Yeah, thanks, Jack. I mean, we've had a very interesting session. You can see how divergent views can be, but they are all heading in the right direction, and which is the fact that the less risk of hemorrhage you can squeeze out of the management, the better it is, and the less risk of thrombosis, the better it is. It is now possible because of the drugs that we have available, and of course the fact that the stents and the trials are consistent in their evidence. Now, I'd just like to probably finish off. We've got some time for question, Jack, isn't it? Before we finish off the final comment.
Yes, we have about 10 minutes actually. So if the other discussants have any questions or comments, please jump in, please.
Yeah.
Question
Philippines,
here in my chat box.
Sorry, carry on.
Yeah, Dr. Azari, there's a question here. Can the data on single month DAPT for high bleeding risk patient be extrapolated to all stents, or is it just relevant for the few stents that have proven safety and efficacy in the literature? So I think anybody can take a shot at this.
Okay, that's a loaded question, Jack. But I think you want to take that since.
So anyone wants to take that? If not, I can take that.
Anybody
if
else?
you want me to answer the loaded question.
Asri is holding the microphone close to his
So with
chest.
the data?
I think that's a difficult question. I mean, in the past, we know there was a lot of difference between stents, and I still think that every stent is different, the stent platform and so on. And I think I'll go where the data is, so I won't extrapolate to other stents, and especially in a setting of acute coronary syndrome. If you look at master DAPT, what was interesting is more than 50% of patients with acute coronary syndrome. So I think that's where the worry is, the risk of thrombosis, and less so with the other ones are more stable if you do it right. But I think more than 50% of acute coronary syndrome. So to extrapolate to other stents, I'm very, very cautious. And we also use a lot of, the other thing we didn't talk about is drug-eluting balloon. So we do use that a lot in my country, in some of these cases where we are scared that we might not be able to, diffuse this small vessel and things like that. Yeah, thank you.
Thanks,
So
Asri.
maybe I jump in a little bit, Azari. I jump in a bit to that question, which is a great question. So the question basically asks, is the truncation of DAPT to 1 month a class effect in the current generation, third generation DES? The answer is twofold. I think one is that the straightforward answer is no. You cannot extrapolate, and I think you need to base on the best evidence that is published. But not all the trials are actually the same. So what the trials tell us is that if you do truncate DAPT due to the concern of high bleeding risk, there is a price to pay, particularly for the ACS subgroup. So the thrombotic ischemic event rates are still high for both groups that truncate. It's just that it's equivalent in both groups when you compare a DES versus a bare metal stent. And it's also actually the same hit for DEB versus DES. So even in DEB, you still have to give them 1 month of DAPT. It's not as if you're shortening less than that. So I don't think it's a very good alternate strategy for this group of patients, especially if there's a lot of dissection. But the second part of it is also true. Now we got more and more evidence, particularly the master DAPT, to say that at least in this subgroup, you can reduce it to a month. There's enough patient numbers in my mind to be quite happy to say that at least 1 month of DAPT is a good enough for this class of stents. We have other trials looking at this, like the REDUCE trial with the combo stents, but they use up to 3 months of DAPT before truncation. So I think my own comfort level is as best as possible for the ACS indication, 3 months of DAPT before truncation. Thanks, Azari.
Thanks, Jack. And I agree with both the opinions. I think these are device-specific trials. They are very strict criteria, and I think we have to go on data. And I think the data does give us some comfort in making that choice. I just want to bring up one more issue, which is the patients on NOAC or the newer anticoagulants and beyond 12 months. I mean, how many of you would be comfortable to just continue at NOAC without the antiplatelet? And if there are, would you default that to an OAC alone, or with antiplatelet and OAC? And I know there are exceptions to the rule for very severe lesions and so on. But in general, what will be your practice for these patients requiring anticoagulation? Kamraj, maybe?
Thanks, Dr. Azari. I guess I said that this all depends again on how complex the procedure was. Again, balancing thrombotic and ischemic. So I guess if it was a complex lesion, rota, left main, etc., I may continue with OAC plus SAPT. If not, if it's a straightforward lesion and all that, and we know that the patient is considered to be possibly a high bleeding risk patient, then I may think of just the NOAC and see what happens
Right.
after a year.
Thank you. Perhaps I can squeeze in a question to our Filipino colleagues. Anyone from the Philippines? On a similar note?
I have to agree with. Hi, I have to agree with him. I think for those complicated patients, ACS, minimum maybe triple therapy of 6 months, maybe even 12 months. But for those, lesser subsets or less complicated or more stable patients, maybe 1 or 3 months. Well, more data are coming in, so maybe we will be more enlightened in the coming years. Thank you, bro.
Thank you. Jack, so one question
Yes,
to you.
you can-
Beyond 12, sorry, you wanted to say, Kamraj?
No, I think the important perspective here is that in the end, the management of DAPT for our patients is very centered around what the physician decides, and it varies from case to case, and it may vary from physician to physician. That's one. And the second thing is, like, as we know, NOAC, OAC, triple therapy, and all that is still very new for us, and really no real what do you call it, hard and fast guidelines or rules that we can follow. So I think it's still very operator dependent.
Right, thanks. That's relatively uncharted territory, Jack. So maybe you can throw in your lot in regards to the antiplatelet and anticoagulation beyond 1 year in the majority of your patients post-PCI.
So maybe we go back to data and guidelines. I think the guideline is very, very clear. So let me restate that. After 1 year of any therapy, including having a stent in, it's actually pretty safe to down titrate to oral anticoagulant alone based on the WOS trial. And the latest one, the FIRE trial for Rivaroxaban versus Rivaroxaban plus an antiplatelet agent, it does shows that there's no increase in ischemic outcomes if you just down titrate to NOAC alone, even in the group that has stents. There is a caution though in a subgroup analysis for the FIRE trial when they have very complex bifurcation stenting multiple stents. Maybe there is a signal. So in those groups, I think all of us recognize the patient group multiple stents, bifurcation, left main. Maybe in that subgroup, you are probably a bit cautious, and I think no one can be faulted if you extend and continue antiplatelet together with the OAC. On the caveat that renal function is normal, on the caveat that the patient doesn't have high bleeding risk and has bled before on the dual therapy even. So I think in that subgroup, you have to be very cautious with a combination therapy, especially for GI bleeding, less so for intracranial bleed. Thanks to you.
Right, that's very sensible practical advice there. Asri, you have a comment?
I have a question to the rest of the panelists. In the stable patients, when you do an angio and you find that got complex disease, you stage them. There are some older interventions that actually give them a trial of DAPT for 2 weeks and see whether they bleed. Does anybody do that? Instead of stenting them, give them a trial and see 2 to 4 weeks.
So since I'm the older ones here, no, I don't do that. But yeah, I mean,
maybe
Jack,
I can.
have you seen or any
Yeah.
Kamraj on your end or the Filipino colleagues?
No,
So
no,
maybe I
no,
can-
no such thing. I mean,
So maybe I can just take that. Asri, your comment is actually very good. I have practiced that for a few patients, but let me state the evidence why I think that is one valid option. The reason is because when patients manifest bleeding, they usually manifest bleeding early. They don't manifest bleeding if they're already tolerated for at least 3 months to a year. So the patient that bleed is a patient that you just initiated dual therapy or you just initiated NOAC. So you want to do, you can challenge them, whether is it bleeding within 2 weeks or 1 month. That part I don't have a good answer, but if they can tolerate at least a month of DAPT without bleeding, I think it's pretty safe to say that they will tolerate a bit longer. But then you're exposing them to a longer duration. Yeah, thanks.
Yeah, you're right. I mean, most of the bleeding occurs in the first 2 weeks, if you see. At least 70% of the bleeding.
True.
Yeah, thank you.
Fair. So I think we are almost come to the end now, Jack. It's been a very interesting session. I've enjoyed it. And before I hand it over to you, I'd like to thank my co-chair, Jack, and Astri here. And of course, all our colleagues on the panel as well as virtually. We hope to meet sometime in the future. Thanks to Terumo and all the audience live as well. We have a few people as well as those on the online. So Jack, perhaps I can invite you to give some closing remarks before we finish off. And once again, thank you for giving me the honor to chair this session.
Thanks, Azari. Firstly, I'd like to thank also all the Malaysian and Filipino colleagues for joining us in this Saturday afternoon discussion in this roundtable on a very important topic of titrating our thoughts and guidelines on DAPT use in our group of patients. So I think today we just had a quick taster of why we need to change practice based on evidence. There's more to come, so look out for the next section when they discuss more in depth into the evidence, as well as how you can consider changing your DAPT practice. So watch out for section 2 for today's Master DAPT program, and thank you very much for staying the full hour. Thanks, everyone. Bye-bye.
Thanks, Jack. Thank you. Bye-bye.
The future of healthcare relies on exceptional efforts from dedicated professionals, like the teams of people at Terumo Interventional Systems. Imaginative ideas, relentless attention to detail, and a never-give-up attitude define the culture of our company. We thrive on challenges and seize opportunities. A promising new world of interventional medicine is opening up right before us. Our greatest commitment is to the success of physicians on the front lines seeking better outcomes for their patients. Every day, our solutions help them overcome barriers and implement new life-saving treatments. As the field becomes increasingly complex, we continue to innovate. At Terumo Interventional Systems, we are honored to play a role in shaping the future of healthcare. Our commitment to improve patient treatment and quality of life will never end. Pushing boundaries.
The high bleeding risk patients consist of a large population within our PCI population. And currently there is not much evidence yet what is the most optimal DAPT regimen for those patients.
In the last years we have seen probably more than 10 different DAPT studies comparing various DAPT durations. However, in none of these studies, patients with high bleeding risk features were included. And in fact, we suspect that the trade-off between ischemic benefit and bleeding liability could be completely different in this specific patient population. We decided to stick to one specific DES because we think the study will provide a DES specific answer, and we have seen and actually we have used many different drug-eluting stents already well available on the market, but in fact we think that they may differ quite dramatically, at least with respect to the safety, at least when you really shorten DPT and you allow patients already to walk outside without double antiplatelet regimen already after 1 month.
We have chosen the UltiMaster stent for our pivotal Master DAPT trial because the UltiMaster stent is a cobalt chromium thin strut drug-eluting stent with an abluminal biodegradable coating with a short degradation time from which sirolimus eludes.
The rationale for choosing Ultimaster lies on the fact that this stent has actually 1 month CE label, which is very reassuring. Secondly, because we have seen from a Discovery 1 to 3 study very important and reassuring mechanistic information with respect to the capability of the stent to be completely covered already at 1 month at OFDI imaging. And finally, because in fact it has a specific and unique engineering component so that the drug and the polymer is only abluminally placed.
The Master DAPT trial is a really unique trial because it is one of the largest trials in high bleeding risk patients. It consists out of 4,300 patients.
Including actually Europe, Asia, America. All countries will be actually represented in this landmark investigation, and also the fact that unlike many other studies that are being planned and actually currently conducted, we are randomizing patients to either receive a very short DPT duration consisting of 1 month DPT only versus a more prolonged DPT duration, but still, let me say, still relatively short, consisting of a minimum of at least 3 or 6 months, depending on whether the patient has or does not have a concomitant indication for oral anticoagulation, which of course is one of the HBR criteria. We don't want to include in the primary endpoint of the study the events which are happening the first month after PCI, which is we consider only noise and can only actually in a way bias the study results.
And it is unique because it also incorporates patients on oral anticoagulants or the novel, the NOACs as well. And those patients have not yet been investigated that much so far. So it's really going to be an interesting and very clinical relevant trial. The Master DAPT trial is currently enrolling, although we are still in a startup phase and we have more than 50% of our sites active.
With the current speed, and hopefully we will be able to increase even that speed, we think we can get the study completed by Q1 next year, meaning 2019, and finally have the results of the study in Q1 2020.
The future of healthcare relies on exceptional efforts from dedicated professionals, like the teams of people at Terumo Interventional Systems. Imaginative ideas, relentless attention to detail, and a never-give-up attitude define the culture of our company. We thrive on challenges and seize opportunities. A promising new world of interventional medicine is opening up right before us. Our greatest commitment is to the success of physicians on the front lines seeking better outcomes for their patients. Every day, our solutions help them overcome barriers and implement new life-saving treatments. As the field becomes increasingly complex, we continue to innovate. At Terumo Interventional Systems, we are honored to play a role in shaping the future of healthcare. Our commitment to improved patient treatment and quality of life will never end. Pushing boundaries.
Hello, good afternoon. Welcome to the Asia Pacific, welcome to the Master DAPT DAPT in Asia Pacific organized by the remote company. This is the part 2 of the program, and my name is Tan Hui Chim, and I'm from the National University Heart Center. Now, as you have heard from the part 1 series, which is focusing on why do we have to change DAPT practice, today the part 2 series is how are we going to change our DAPT practice. And we do have 3 objectives in this particular sessions. The first of all, which is to address the key concerns regarding high bleeding risk patients undergoing PCI. The number 2 objective is to derive clarity as well as confidence from the current clinical evidence. And the number 3 is to give practical guides to our audience here insofar as DAPT change strategy is concerned. So to address this very important topic, I have in the studio here my 2 esteemed colleagues, Dr. Aaron Wong, who is on my immediate right, and Dr. Chin Chi Teng is on the far right, and they are both from the National Heart Center, Singapore. And not only do we have Singaporean representations, we also have our colleagues from Indonesia as well as Vietnam. So from Indonesia, if you look at the screen on the far left, Dr. Doni Firmant. From Jakarta, Dr. Teguh Santoso, and Jakarta as well, and Dr. Bambang Budiono from Makassar. How are you all? And
Very
also
good.
in
Very
Vietnam,
good.
I'd like to welcome my 2 Vietnamese friends, Dr. Nguyen Hun Thuc, I hope I pronounced your names correctly, and Dr. Ngô Minh Hong, of course, I will know you very well. Welcome to this sessions, and I look forward to a very exciting discussion with you guys. Now, we are all interventional cardiologists here, and in contemporary PCI, we are now facing patients with increasing lesion complexity as well as patient complexity. And so all this means that when you do contemporary PCI, you are looking at situations where there is increased risk of ischemic complications. And when you throw in this element of a high bleeding risk, this complex interplay becomes even more pronounced. So now the interventional cardiology community is faced with the challenge of balancing the ischemic risk as well as the bleeding risk in patients undergoing a complex contemporary PCI. And how do we actually manage this balance here? It is a challenge here, and that's why we are all here to talk about it. But certainly risk stratification of patients with regard to DAPT duration and composition becomes very important. So I think to start the ball rolling, we are going to be focusing on 5 areas of discussions. The first of which is we're going to talk about in general the advantages and disadvantages of long versus short DAPT. And on this particular topic, I'd like to invite Aaron perhaps to give your comment as to how do we navigate and understand from all those clinical trials comparing short versus long DAPT in patients undergoing PCI.
Okay, so indeed, the high bleeding risk patient actually represent about 40 to 50% of a population in our daily PCI. So it's a big market share, and the stent company always usually don't want to lose out in this market. And so indeed, there are many trials in the market now. Actually, to look at short DAPT versus long DAPT. Now, the first one that actually come to the trial is the BioFreedom, where 1 month DAPT comparing devices, DES versus BMS, and show that 1 month DAPT is safe. And the second trial is the Onyx one, where comparing the DES versus DES, the Onyx versus the BioFreedom, and again show that the Onyx is non-inferior. And this is only talking about 1 month DAPT. So people will question, what happened if they did not compare when they extend to 6 months or 12 months, whether the results will be any difference. So there are other trials also using historical control, the Zion's 2890, using the previous trial to compare the 1 month DAPT. So some people may question the validity of this sort of comparison. One unique trial is, of course, is the Master DAPT study, which is one of the largest trial comparing, actually is not comparing between devices, but comparing the duration of the DAPT, 1 month versus 6 to 12 months of DAPT. And it shows that there is no price to pay if we shorten the DAPT. So I think I foresee that from next few years, most of the stent company will have come up with trials that to show that there is safe to shorten the DAPT, and for interventionists to make it much easier so that we don't have to worry about patients that with high bleeding risk. Any stents will actually do for this group of patients.
Well, thank you, Aaron. Perhaps I also can invite Chi-Teng to give your insights on this issue here. Obviously, long DAPT has got its advantages of in reducing stent thrombosis and myocardial infarction. Short DAPT can reduce bleeding risk and as well as death, apparently, in some group of patients. So, what is your take on this?
Yeah, thanks, Richim. So, this is a very important question. So, this question of long versus short DAPT duration, and so after so many years, we're still here having this debate because really there's no easy answer. I think Aaron has shown some of given some of the data on the short DAPT duration, but I think maybe we take one step back and as you alluded to, why do we do PCI, right? So when we do PCI, we have a patient in front of us who have certain factors that predispose his or her to ischemic events, right? And these mainly to do with the plaque. They have plaque buildup in the coronary vessels, and this plaque tends to misbehave, gives them symptoms, sometimes results in acute coronary syndromes. And in order to mitigate that, we perform PCI. So in PCI, we then introduce additional factors into the mix, right? So we perform an intervention, we distort the vessel architecture, we introduce a foreign body that then introduce additional thrombotic risk. To mitigate this thrombotic risk, we come up with a solution which is antiplatelet therapy, which introduce bleeding risk. So it's this whole balance. And as you know, from before, the standard way of treating this was that so-called sweet spot was 12 months, right? And this number really came from, a lot of people felt that it just came from pluck from the sky. And almost immediately after 12 months, this 12-month standard came out, we have trials looking at shorter DAPT duration as well as longer DAPT duration. So we have short trials looking at 1 month, 3 months, 6 months, and we have trials that are extended up to 30 months. And we're going to talk a little bit more about these trials in later. But to summarize, we've got meta-analyses looking at all these trials now. And I think it's quite clear now that from the published meta-analyses, most of the meta-analyses agree that actually short DAPT duration as compared to long DAPT duration, there's not much difference in terms of ischemic or thrombotic events. And encouragingly, actually, there's even advantage in terms of reducing bleeding events. So I think that really is the kind of state of play that we have now. But with the very important caveat that these are meta-analyses, even with randomized controlled trials, is this really applicable to the patient that's sitting in front of you, right? And so I think that's what we're going to discuss this afternoon. Thanks.
Right, so selecting the patients, targeting the right sort of anti-thrombotic regimen and the right patients is of course a challenge. So there are all sorts of patients that we encounter, from stable patients with chronic coronary syndromes to unstable patients with NSTEMI and STEMI. And so how do we actually direct this therapy strategy? So maybe I can ask Ngo Minh Hong from Vietnam to tell us what is your practice in terms of length of DAPT for your patients? Do you stratify them? How do you decide?
Yes, thank you very much for the question, and good afternoon, everyone. Good afternoon, chairperson, panelists, and colleagues. In my opinion, I totally agree with Dr. Chi-Teng just talked about why we do the intervention for the patient, and that's the reason why we put the patient on the table, and now we have to face with the high bleeding risk. So the length of the DAPT should be relied on the following thing that I list here: that the presence of the high bleeding risk or the high thrombotic risk, the current clinical presentation, devices or techniques new information from the following up when we see the patient at the outpatient clinic. So I go in detail that the first one is the presence of the high bleeding risk or thrombotic risk, or the tolerability, the course of therapy, involvement and the adherence. For example, the AIDS polymedicated at the economic situation, especially in Vietnam, we had some patients that cannot afford for the therapy as well. So this is the important that for the next step of the whole procedure. As ASC guideline recommended, in most cases, we have to we have to see that the patient is the high bleeding risk first, and then we have to look at the high thrombotic later on. But some situation, for example, left main intervention or even the proximal segment of the big vessel or large remaining vessel, in my opinion, we have to put it the thrombotic risk or thrombotic issue first, and then we have to evaluate the bleeding risk later on. The second opinion is the clinical presentation, as the Dr. just said now, that the patient come to us with the ACS or the stable coronary artery disease. So we have time to classify the patient when we see the patient at clinic. But with the ACS, sometimes we don't have enough time or information to know that or to predict the bleeding tendency or the for the ACS patient. That's the second one. The third one is the lesion complexity or the position of the position, for example, left main vessel or the multivessel disease through bifurcation, that we have to put two stents or even more than two stents, and diffuse disease, severe calcified lesions, or even large remaining vessel, we have to do the stenting if the patient cannot follow the if the patient don't want to undergo the operation. So the fourth one is the device property or techniques. Sometimes we have to pay attention on the DES, for example, the coating, for aluminum coating or ceramic coating, the structuredness of it. I'm mentioning about the metal like cobalt, chromium, or the platinum, etc. Or sometimes we have to mention about the design of the stand as well, because when we do the intervention for the bifurcation, we have to pay attention on the design of the stand as well. So the last one is bioabsorbable polymer or durable polymer. Also in my, I put in the my practice. So and something is about the DEB that some title already coming out, and the technique as well. Sometimes we have to calculate between the one or two stand together, one versus two stand, or even short versus long stand, or even stack procedure, or only one procedure. So the last one is new onset of bleeding or bleeding risk or thrombotic risk during the following up. If we see the patient that they have the new bleeding issue or even just the bleeding risk on patient recently stented, so we should immediately reconsider the length of DBT. On the contrary, if we are facing the thrombotic risk or thrombotic issue, so we should reconsider the DABT. Even in this situation, we should prolong the DABT in order to protect the patient from the thrombotic issue. That's my opinion. Thank you.
Thank you very much, Hong. Obviously, there are a lot of areas that you have covered, and you have brought in things like lesion complexity, whether they are ACS, whether they are high bleeding risk, and so forth. So Teguh, you're back on with us. I want to hear from you. I know we all want to go towards a shortened DAPT regimen, but what sort of patients are you going to be giving as far as extended DAPT goes? I mean, we have trials like DAPT trials, we have Pegasus that tell us that certain groups of patients benefit from extended regimen. So can you share with us who are the sort of patients that you would not consider short DAPT, but rather go on the extended DAPT?
Yes, thank you so much. I'm so sorry, I have a little bit of a problem with my internet. But we know that the current guidelines recommend only for 6 months for patients with chronic coronary syndrome. However, dual antiplatelet therapy is recommended for at least 12 months after an episode of ACS event, followed then by single antiplatelet, usually aspirin, according to the guidelines. So then this has to be continued indefinitely unless the patient has high bleeding risk. For patients with in high risk of ischemic events, DAPT it's recommended to be continued beyond 1 year. This is a reasonable approach, but it is based on the prerequisites that the patient is not at high bleeding risk. So extended depth beyond 1 year might not be suitable for patients who has a high bleeding risk. For this, it is recommended by all the guidelines to continue dual antiplatelet medication like aspirin plus prasugrel or aspirin plus ticagrelor or aspirin plus clopidogrel after 12 months with the same combinations or with a low dose of rivaroxaban. But also, we know that patients undergoing complex PCI, like for example, triple vessel disease or patients with triple vessel stenting, triple stent implantations or long CTO, left main situations, or patient undergoing atherectomy and so on. These are all complex lesions. These patients may also benefit from longer depth durations, like more than 12 months. We also have to know that in the recent year, a novel approach of dropping aspirin after a period of dual antiplatelet medications has emerged as a strategy aimed to reduce bleeding while preserving efficacy. So DAPT followed by chronic P2Y12 monotherapy has now also been tested in a number of randomized trials, like, for example, Twilight, Tycho, Stop Depth, Smart Choice, and so on. And this lead us to use, this is also recommended by the guidelines, combinations of aspirin and ticagrelor only for 3 months, for example, and then continued with ticagrelor monotherapy. At the present time, the totality of evidence doesn't support the routine use of platelet function tests or genotyping. And also, we also know that the current 3 risk scores, for example, ST score or Paris score or DEP score, may not be necessarily applicable to our populations in our area. This has also been published by, investigated and published by the Chinese investigators in the recent journals. So, in short, these are my view and also following the recommendations. But I would congratulate the investigators of the masterclass depth that showing that indeed with the shorter depth we can have a good result with less bleeding complications even in high risk patients populations, including ACS patients, with a shorter term of depth administration.
Much the goal. So I think I can summarize that. Obviously, most of the time we would like to go with a shortened DAPT for our lower risk patients, and of course extended DAPT for a higher risk group of patients. But for a particular subgroup of patients with high bleeding risk, perhaps this is a group that we will have to be particularly concerned here. And I want to now quickly go on to the second scenario here, where we're going to talk specifically on the high bleeding risk group of patients. And here I'm going to ask Aaron here. There's certainly a lot of high bleeding risk trials that have been published. In fact, I can broadly divide them into 2 groups. One group is really stent versus stent. The classic will be the leaders-free, 1 stent of Gazelle versus a Biofreedom. But this one has got no comparison as far as longer duration DAPT. Both are just 1 month. So it's a stent versus stent. And the other group is 1 stent for short DAPT, but compared with a historical performance of the same stent in past cohorts of patients. So we don't really have a trial that compares a short versus long for a particular stent product until MasterDep comes along. So can you take us through all these clinical trials and give us your perspectives on this?
Yeah, I think I mentioned just now in my the first questions. Yeah. So I think MasterDep study is one of the most robust study which is available, actually comparing one short DAPT versus long DAPT, and it shows that using the same STEM platform, actually there is no price to pay for increasing the ischemic event. So we are actually sort of pretty confident that using the Ultimaster stent, that in shorter duration of DAPT actually is pretty safe.
And Doni, can I ask you? So, for a interventional cardiologist facing a patient in front of him, when you have ischemic risk, when you have bleeding risk, I mean, is there a way where we can actually sort of re-stratify them by some kind of a risk score, or do you think a risk score is useful at this point in time from a practice, or do we just go on our own personal gut feeling and experience? So what is the value of some of the risk scores that is available in the literature, in your opinion?
All right. Thank you, Prof. Tan. Thank you for having me. Good afternoon. So, yeah, of course, there's a lot of bleeding risk scores available. And then sometimes it's impossible to compare one another, which one is better, one in another. So it really depends. If you look at some meta-analysis, came up with a different C value or concordance score. So there's a one meta-analysis last year launched that the C value between 0.7 to 0.8. So means that there's some variation. So it really depends on the risk scores and also depend on the major hemorrhagic event definition you used. So there is it's almost impossible to say that one risk score is is better compared to with another. For instance, the Cruzet score showing a good C statistic value around 0.8 means that is a good model for predicting in hospital hemorrhagic events. But in the other, the newest one score, well, we call it the BMAX score, validated in the Sweethearts registry, showing that the C value is around 0.65, means not good enough. So that's why before we using a risk score, we should put all available data from patient and should be carefully analyzed before using a prediction score, and without, most important in my opinion, without neglecting the clinical judgment. And if you look at the EAC and then the ACTS guideline, you should focus on the treatment of the APT, and you should it doing personalized. Personalized means that every patient has a different risk score because it can be changed by the time. What you look at, maybe it will be different the next month. So that's my opinion, Prof. Tan. Thank you.
Thank you very much, Doni. I like this judgment part, a clinical judgment part in deciding the duration of DAPT. Can I ask Dr. Nguyen Hoon Kook, how do you deal with a high bleeding risk group of patients in your practice, given the constraint I know of your public healthcare system in your country? So, do you use any risk score? Do you use any particular type of stents, or do you use any particular type of antithrombotic regimen for your high bleeding risk patients?
In my my local practice, we follow the guideline of my country. Or if we don't have, we follow the guideline of the American ESC, and we count the cost before we decide to choose for the patient. And I very like I very agree with Dr. Doni. We must to personalize patient, and now in the clinical we use the app on the smartphone. Now on the score app scores on the smartphone have the app use, so we easy to use. That's the first choice for my local state, and but sometimes we must to we treat the patient, not treat the disease. So we must to personalize patient. Example, we have the ACS patient. we must use the DAPT, Decapilor plus aspirin for 1 year. But the patient have some day after that, the patient have side effect of Decapilor is short break. The symptom the same, the heart failure. So we check the clinical, do the echo to check the EF, no, and last step to check the anti-RONB, but no more. We think that the symptom not affect so much for the patient. So we try to keep the Decapilor as long as possible. But sometimes we must to change to step down. We change to Decapilor, lorbidoxine, if the patient cannot accept the symptom. So I think we must to personalize patient to treat. Thank you.
Thank you very much. So I gather here is that risk score is helpful perhaps as a research as well as for comparisons of maybe outcomes in various studies, but at the ground level, people still rely very much on their own clinical assessment in deciding the duration of antithrombotic therapy for patients. So that's good. So I want to go to the next part of the discussion. So the reason why we have been able to go on the shortened DAPT compared to the past is because it would appear that the current stent technology has progressed so much that we don't have the same problem like the first generation DES, where we're so worried about late thrombosis and very late stent thrombosis. And that's why now we are all going into a short DAPT regimen of even 1 month or to 3 months and so forth. So can I ask Bambang Budiono, do you think the current second generations of DES are as good as one another in terms of its safety, such that we can use any stent for our high bleeding risk group of patients? Or should we strictly go by the stent trials that have utilized this particular type of stents in HBR patients and go by only the evidence that has been presented, say, for example, Ultimaster in the Master DAB or Zion stent in Zion's 2890 and so forth. So do you think we should be stent specific, or you think we can generalize to all DES?
Okay. Thank you for your question, Prof. Tan Wei Chim. Delighted to be a part of this roundtable discussion. So if we talk about bleeding versus ischemic trade-off in high bleeding rate patients, we all know that appropriate stent selection is one of the crucial strategy with regard to minimize stent thrombotic events due to incomplete strat coverage by early endothelialization, so that we may shorten the APT duration in order to reduce bleeding complication. So as you have mentioned earlier on, that after drug-eluting stent was introduced in early 2000, first generation regimens appeared to be associated with a higher risk of cardiac mortality or MI. And it was mainly because of increased risk of late and very late stent thrombosis compared with the bare metal stents. And now, as you have mentioned, we have several options for stent selection for patients at high bleeding risk. And the third generation drug-eluting stents like BioFreedom, Onyx Science, as well as Ultimaster stents have latest stent technologies with improved drug release kinetics, stent materials or platforms, and more biocompatible or biodegradable polymers. And they have already received CE mark labeling for 1 month DAPT duration for patients in need to stop DAPT early. And we may consider actually to use it for our high bleeding risk patients, but whether we can use it interchangeable or not for high bleeding risk patients, we need to closer look to the baseline characteristics and design study inclusion and exclusion criteria of the respective clinical trials. Let's say Science 28 study as we know, exclude STEMI patients. So we don't have any strong evidence for STEMI with high bleeding risk from science, while Ultimaster enrolled about 50% ACS patients, including STEMI. So I think because each drug-eluting stents has different technology in terms of stent platform, drug concentration, biodegradable polymer, and so forth, the choice of the third generation drug-eluting stents for high bleeding risk patients is not always interchangeable for all clinical scenarios. I think that's my comment.
Thank you, Bang Bang. So certainly stent choice is important here based on the evidence. Maybe I want to ask Dr. Goh Ming Hong, now besides choosing the right kind of stent for high bleeding risk patients, are there right kind of techniques that we should be using when performing PCI in a high bleeding risk patients in order to reduce bleeding and as well as ischemic complications?
Yeah, thank you very much, Professor Tang Hui Chim. So, good afternoon, everyone. Again, in order to minimize the bleeding risk and get ischemic complication during the BCI of the high bleeding risk patient, in my opinion, we should follow some following thing that I list here. For example, we have to do the transrectal approach. Imaging tools have to be used, and devices or techniques, and then the simple and reasonable procedure. So I go in detail that the transrectal intervention in my current practice. So at General Hospital, we use the transrectal intervention for the about 97.9%, in which I use the 1.58% of patients with the balloon assisted technique in order to protect the radial artery, so that protect the bleeding. So BAT, the really adding more success rate and minimize the risk of bleeding when we use the transrectal approach. Besides that, we tend to use the smaller catheter. For example, sometimes I use a 4-French getting catheter, 5-French getting catheter, or even 6-French getting catheter. In case of bigger catheter needed, for example, 7-French getting catheter, I use the BAT again in order to protect the artery from the crease in order to go to the heart, and then we perform the procedure. I done the sheetless system. The second one is the imaging tool that I nowadays I use quite a lot of IVUS. We don't have OCT. We use a lot of IVUS in order to do the intervention for the patient that I see that they have a high rate of bleeding, in order to optimize the PCI procedure. Before the procedure, so we all know that the imaging tool can give us the enough information that about the left main, the bifurcation, or even the length of the stent, etc. Even the calcify. And after the stenting, we can use the imaging tool in order to give us the information about the up position or the expansion of the stent or even dissection. And the third one is the proper use of the devices or techniques. So I mentioned here we have to use the evidence-based medicine, like that Dr. Baman Budiano just mentioned about that. We use the trial that just came in now. Couple of years ago, we know the trial coming that the global leader or the senior trial, or now just last year we have the master DAPT that's coming out with a lot of on corner of the patient come to the cath lab, so we have the evidence from that trial as well. So that is in my current practice. So for the high rate bleeding of patient, we use the POBA. I use POBA for the patient, or even sometimes I use the DCB as well for the diffuse disease. I don't want to put so many stents for the patient with the high rates of bleeding or even the bleeding risk in. I just put the stent when I have to face with the dissection, and with the bifurcation, I use the provisional stenting. Nowadays I use a lot of gel balloon technique for the true bifurcation. If we don't need to put 2 stents for the high bleeding risk patient, because when we put too many stents for the high bleeding risk patient, or even we have to have the triple when we face with the bleeding if it happen. And the last one, maybe we should perform as simple or reasonable as possible procedure for the for the high bleeding risk, because they have the patient to overcome the bleeding or the tendon of the bleeding. So with the patient with the complex procedure or even the multivessel disease, so I have to put the stent by stent together. And the first procedure to see that the patient can tolerate with the procedure or not, and then a couple of days after that, so I put the second one, and as less as possible. That's my opinion, Professor Tang Hui Chim and my colleagues. Thank you.
Thank you very much, Hong. Certainly very important tips and tricks with regard to minimizing risk of bleeding and ischemia. Even for transfemoral approach, I think nowadays people are using radiologic guidance, ultrasound guidance, micropuncture to also reduce the risk of bleeding. So maybe I ask Chi-Teng, so with all these clinical trials telling us, or high bleeding risk clinical trials telling us that, the stent is quite good in terms of early healing, and that DAPT 1 month is good even for high risk complex patients. So for patients with left main 2 vessel stenting involving the left main or multivessel PCI, do we have to care about whether these complex lesions require longer DAPT, or can we be confident that even in such complex procedure, complex lesion, a DAPT of 1 month duration is good enough actually for most of our high bleeding risk patients?
Thanks, Jim. Yeah, that's a very important question, complex question which deserves a complex answer. So I think, as Prof. Togo has already kind of alluded to, when the more complex your procedure, then the inherent understanding is that you need to perhaps be more aware and more concerned about ischemic and thrombotic risk, right? So I think the situations that you outlined just now, a stent in the left main, or tooth stents, 3 stents, long lesion length, bifurcations, all these imply lots more metal than a normal case, and importantly, metal in a very dangerous area. So that would be the paradigm here, right? So you want to make sure that you get that balance correct. So I think whether or not you can shorten the DAPT down to 1 month, if you really, really need to in your high bleeding risk patients, I think that's really informed by the trial design. So you should really look at the individual trial designs, and some of the trial designs have specific subpopulations looking at complex lesions. I think the bigger question also is whether or not it makes sense to try and then shorten the DAPT duration as much as possible. And till date, we have some data on this now. So we have some meta-analysis data published a few years ago looking at a variety of short versus maybe what you call standard length duration DAPT trials. And they actually show that our way of thinking has really been quite validated, meaning that the more complex your procedure, if you shorten your DAPT down to 3 months, there is actually a jeopardy. There is actually a price to pay as compared to if you extend it to 12 months. And this is in many ways informed by our thinking. And so really, maybe we should be thinking a little bit more clearly and more carefully before we start to shorten our DAPT duration too much. Now, having said that, there's also slightly, I wouldn't call it confusing, but there's also the other flip side of the coin. So how long do you want to go? Because I think our previous panelists also mentioned, for very complex lesions, maybe you want to go beyond 12 months. Do we have data on that? And now we are starting to get some data on that. So we have some subset analysis from the DAPT study, which, had patients going longer than 12 months, up to 30 months. And in this kind of subset analysis, actually very interestingly, it shows that actually for the complicated cases, the complex cases, beyond 12 months, they couldn't really find a big difference in terms of DAPT duration. So I think what we can maybe take away from this is that in the initial period, the complexity of PCI does play a part in determining DAPT duration. But after you get past a certain stage, and maybe that certain stage is 12 months, then patient factors actually play more a part rather than the actual PCI characteristics. Thanks.
Thank you very much, Chi-Teng. So what I can summarize here is that we want to go by evidence-based as far as the stent choice is concerned. Certainly, Ultimaster being one of the trial evaluated in the high bleeding risk trial will be a stent of choice for your practice, and that there are techniques that we want to observe as well. And again, the message of re-stratifying our patients, targeting the duration of DAPT according to the thrombotic risk of the procedure in which the patient has undergone. So I want to go to the topic of drug now, because I think Teguh Santoso mentioned something about aspirin-free regimen here. And so I want to ask maybe Donny Furman here, in terms of single antiplatelet therapy that follows a DAPT regimen, what is the current practice? What is the choice of your DAPT, and how do you select the type of single antiplatelet for long-term
Thanks.
treatment? Yeah.
All right. Thanks, Prof. Tan. Sorry. So anyway, this difficult question because we need to see whether is any evidence-based trial regarding to answer this question. There is not so many trial, but the one presented in the last ACC is what they call it a host exam by our colleague from Korea. They try to compare between the SAPT with aspirin or clopidogrel after all the patient got the APT with the standard duration, whether it's 12 months or 6 months. And then they follow up until the 2 years or 24 months. So what interesting is that after 2 years, so showing that clopidogrel monotherapy compared with the aspirin monotherapy is statistically significant, reduce the risk of composite all-cause death, non-fatal MI, stroke, readmission to ACS, and BARC bleeding. That's a really important. And then the beneficial effect of clopidogrel was observed in thrombotic composite endpoint as well as any bleeding endpoints. That's also surprising me because we assume that by giving clopidogrel, the bleeding will be increased compared with the aspirin, but the host exam showing not like that. So I think it's a really important trial. So we can choose maybe clopidogrel is comparing with comparing to aspirin if we choose APT. What about the other antiplatelet? I'm afraid we don't have any comparison in any trial yet. Thank you, Prof. Tan.
So Donny, clopidogrel is now your standard therapy, single monotherapy for your patients post-PCI, as I understand. So Aaron, what about, can we use ticagrelor? Because in Twilight trial, they also give ticagrelor monotherapy after 3 months instead of clopidogrel. Do you think that's a good choice as well?
Thanks, Vichy, for the question. So it be increasingly that, like Donny mentioned, that dropping the aspirin, we may reduce the bleeding risk. But what about the ischemic risk? Yeah, for the Twilight study, actually, they compared ticagrelor monotherapy versus ticagrelor-based DAPT after 3 months of successful DAPT without any complication or bleeding. So that's the difference between starting monotherapy of ticagrelor from the onset. Yeah. So it shows that there is no penalty for ischemic event, but there is a lower bleeding risk. But there are studies to show that the TICO study actually showed that this in purely ACS patient, there is also lower bleeding risk. But in Twilight study, unfortunately, the population is a bit heterogeneous. So I think the profile of the patient is quite important. Although we're talking about ticagrelor, but for clopidogrel, when they use the stop DAPT ACS study, actually they found that monotherapy for after a month of DAPT and continue on clopidogrel actually has higher event rate as compared to a DAPT for 12 months. So I think the patient profile is very important. I think for stable CAD, which is about 1/3 of patients in the Twilight study, ticagrelor or clopidogrel may not have a lot of advantage over clopidogrel or aspirin. But for ACA patient, for non-STEMI and STEMI, I think is a ticagrelor for the Twilight study and the TICO study, it showed that actually have advantages. And I think the reason may be because clopidogrel, there is Asian population have a lot of high incidence of clopidogrel resistance. Yeah.
So again, many considerations here, but what we really lack is a trial where we use one of these potent P2Y12 inhibitors from the very outset. Comparing ticagrelor, for example, versus DAPT of aspirin and clopidogrel. The only trial that I can remember is this trial called the ACS, where prasugrel was started as the monotherapy versus DAPT, but that's probably one and only trial. We probably need more evidence. But what about anticoagulant, which also has got anti-inflammatory, antiplatelet property as a sole antithrombotic agent for our patients? Maybe I asked Dr. Nguyen, who could get, when can we use anticoagulant as a single antithrombotic therapy?
Yes. If the patient have the AF, need to anticoagulant, and the patient have the must to do the BCI. So we have on the first year we have the we comment on the Pioneer AF BCI. We can use rivaroxaban 2.5 milligram PED. Try plus with 1 or 6 months with diabetes, and after that we use only rivaroxaban. And after 1 year, we have the AOC a long trial. 75% use the warfarin, only warfarin, and no need to antiplatelets. The result accept, we can accept. And now we have the a 5 trial. We can use NOAC after 1 year. The trial with the result look good. So if the patient with a high risk, we can follow this evidence trial and treat for patient. Thank you.
Thank you very much. So again, many possibility here. Can even use oral anticoagulant in the OAC alone trial as a monotherapy here. So we have a questions from the audience, and the question was, in our patients with ACS and high bleeding risk group of patients, can we really want to, do we really want to shorten DAPT duration, considering if you talk about the stop DAPT ACS trial. So perhaps maybe we will now go to the new scenario, the next scenario, where I'm going to discuss individual patient subgroup with high bleeding risk, and then stretch our faculties here on how they would manage. So perhaps I can ask Aaron, so in your patients who has got high bleeding risk, perhaps who is also on anticoagulant for atrial fibrillations, maybe you can share with the audience exactly how you would do and manage this group of patients.
Okay. So what we know from the trial is that warfarin is bad. Yeah. So for patients who we cannot stop the warfarin, like patient with metallic valve or patient with LV thrombus that required stenting and DAPT. So World study have shown us that triple therapy for a month followed by warfarin plus clopidogrel is safer relatively compared to triple therapy for longer term. But if there is opportunity to switch to stop the warfarin to change to a NOAC, in that case, then most of the study have shown that it's the triple therapy for a month, and then P2Y12 inhibitors plus the NOAC for the rest of 6 months or 11 months, depends on the bleeding risk. Yeah, that's my usual practice.
Right. It's good. So Togu, can I ask you, so for patients with ACS and high bleeding risk, is it safe to shorten the DAPT? Master DAPT has got maybe about close to 50% of patients with ACS. It says it's okay to stop in patient with ACS and high bleeding risk, but stop that to ACS trial tell us that there is a higher incidence of ischemic endpoints if you stop early. So how do we approach patients with ACS and high bleeding risk in your practice?
Very important and difficult question. But we know that according to the 2020 ESC guidelines on ACS treatment, and also 2000 2019 ES guidelines for myocardial revascularization, and also the US guidelines for myocardial revascularization 2021. In ACS patients, DAPT is generally recommended for 12 months or more. However, we know that after stent implantation in high-risk bleeding patients, in the guidelines I mentioned precise depth score of 25 or more, and also risk stratification according to the ARC criteria. They said that after 3 months, we may consider single antiplatelet medications or stopping the dual antiplatelet medications. The level of evidence is 2A/B. And in patients with very high risk of bleeding, for example, patients with recent bleeding episodes or planned surgery, non-deferrable surgery in the very near future, even 1 month depth therapy should be considered. A level of evidence is 2AA. Other process de-escalation, so P2Y12 treatment, for example, switching from more potent agents like prasugrel and ticagrelor to clopidogrel, especially for ACS patients deemed unsuitable for potent antiplatelet inhibitions. This approach can be guided by platelet function testing or CYP2C19 genotyping, or unguided based on clinical judgment. In the recent years, we know that a novel approach of dropping aspirin after a period of DAPT has emerged as a good strategy to reduce bleeding. And it's mentioned also by the previous panelists that DAPT followed and by Professor Tan also, followed by chronic P2Y12 inhibitors, like, for example, demonstrated in the Twilight study, TICO study, Smart Choice, and STOP-DAT. We can also change the dual antiplatelet medications after 3 months to just single agents like ticagrelor monotherapy. However, we know that this master DAPT trial brings new light to all of us. We know that the current second generation strains are generally very safe, and also recent studies have shown a demonstrated benefit and safety of shortening DAPT duration in using second generation stents. And this master DAPT study recruited 4,500 participants or patients, and they all were in high bleeding risk. So patients at high bleeding risk, and they recruited also complex cases. More than half of the patients had ACS, and many of the patients also has multifacetal disease. And they very nicely demonstrated that shortening DAPT administration to even 1 month is not associated by increased ischemic event after implantations of course, ultra-master family type of stents. So I think this brings new light to us and our daily practice. Thank you.
Thank you very much, Teguh, for that insightful comment again. You know, it is very nice to where we can, before the procedure, plan for what is the duration of the DAPT, you know, tell the patients what is risk and so forth. But sometimes in an apparently normal bleeding risk patients after PCI develop a massive bleed. And then now you immediately have a high bleeding risk patients in your hands. So Doni, can you share with us how you would approach somebody who develop maybe a major bleeding complication such as GI bleed or intracranial hemorrhage 1 day after your PCI of the left main? So how do we handle such patients in real life?
Thank you, Prof. A very important question. And then we know that we are Asian, tend to have more bleeding compared to the Caucasian. So I know in my practice, we just follow the EEC guideline, which categorized the bleeding into a trivial and mild bleeding. So if you have the patient with trivial and mild bleeding, you just continue the APT while observing the patient per day. But if the patient have moderate and the severe bleeding, that's the problem to begin. I think in my approach that first I will consult or I will talk or build the bleeding team with my neurologist or gastroenterologist to discuss of this patient, because each patient have different behavior, have a different disease. So if the patient have a moderate bleeding defined as the blood loss more than 3 gram per deciliter, but clinically stable, so I would, according to the guideline, we can choose to SAPT with preferably P2Y12 blockers, and don't forget to get a PPI for this patient, and can come back to the APT once the clinically the better for the patient. But the problem if the patient come with a severe bleeding means that let's say the blood loss of more than 5 gram per deciliter, or the hemodynamic unstable, for instance, the patient with the massive hemorrhage bleeding. So that's why the discussion between us and the other specialists is really, really important. Whether you can, downsize to the SAPT, or even you must stop the antiplatelet because it's, because of the life threatening. So there's no choice at all. But sometimes after you discuss with the other colleague, so they also have some opinion. Maybe we don't have to stop all the APT. Maybe they have some technique to allow us to at least give the one as APT for this kind of patient. So it really depends on the clinical of the patient, and how dependent bleeding team occur in your hospital. That's pro.
Thank you much, Tony. Indeed, a multidisciplinary approach is necessary, because just about 2 months ago, I have a patient who I stented the left main, and then the next moment, few hours later in the CCU, he developed this massive diverticular bleed, and so he was pouring out 5 grams of blood from his rectum, and surgeons whom I called say there's no way he can go in and do an emergency scope. He's not going to be able to see anything and cannot do an emergency colectomy, but I've just stented the left main and I can't continue a DAPT. So that was a real dilemma. So what I did was I managed to persuade my interventional radiologist to go and find the bleeding spot in his mesenteric artery, and we successfully found that bleeding spot and embolized it, and that took care of the problem. So indeed, a multidisciplinary approach is necessary for someone who developed acute bleed after a PCI. So I think we have covered quite a lot of grounds. I think to address the questions of how do we change our practice as far as DAPT goes in high bleeding risk group of patients, I can only summarize by saying that we do have a master DAPT trial to guide us by in terms of changing the DAPT regimen. So I can summarize the DAPT, what the lesson that I learned from master DAPT trial is that, number one, if you have to shorten the DAPT regimen, there's no increased ischemic complications, at least based on the trial. Number two is that in the by risk group of patients, both ACS as well as high bleeding risk group of patients, the abbreviated regimen seems to be just as safe as well. And the third thing to emphasize here is that adding anticoagulant for a long period of time and extending a triple antithrombotic regimen is no good. So as far as possible, you want to shorten the combination of antiplatelet with anticoagulant and quickly go to a single OAC if you can, as quickly as possible. And finally, I think that it is hard to generalize the choice of stent in all patients, but when you strictly look at high bleeding risk trial, I think Ultimaster trial is now the only stent that has been shown to actually be just as safe when used in a short regimen compared to a long DAPT regimen. So with that, I really like to thank my fellow colleagues in the studio, as well as way far away from Indonesia and Vietnam, for joining me this afternoon in this very wonderful and educational symposium. I hope all of you have benefited from these sessions and also enjoyed the session as much as I have. So thank you very much again, and have a good weekend ahead.
The future of healthcare relies on exceptional efforts from dedicated professionals, like the teams of people at Terumo Interventional Systems. Imaginative ideas, relentless attention to detail, and a never-give-up attitude define the culture of our company. We thrive on challenges and seize opportunities. A promising new world of interventional medicine is opening up right before us. Our greatest commitment is to the success of physicians on the front lines seeking better outcomes for their patients. Every day, our solutions help them overcome barriers and implement new life-saving treatments. As the field becomes increasingly complex, we continue to innovate. At Terumo Interventional Systems, we are honored to play a role in shaping the future of healthcare. Our commitment to improve patient treatment and quality of life will never end. Pushing boundaries.
The high bleeding risk patients consider of a large population within our PCI population. And currently there is not much evidence yet what is the most optimal DAPT regimen for those patients.
In the last years we have seen probably more than 10 different DAPT studies comparing various DAPT durations. However, in none of these studies, patients with high bleeding risk features were included. And in fact, we suspect that the trade-off between ischemic benefit and bleeding liability could be completely different in this specific patient population. We decided to stick to one specific DES because we think the study will provide a DES specific answer, and we have seen and actually we have used many different drug-eluting stents already well available on the market, but in fact we think that they may differ quite dramatically, at least with respect to the safety, at least when you really shorten DPT and you allow patients already to walk outside without double antiplatelet regimen already after 1 month.
We have chosen the Ultimaster stent for our pivotal Master DAPT trial because the Ultimaster stent is a cobalt chromium thin strut drug-eluting stent with an abluminal biodegradable coating with a short degradation time from which sirolimus elutes.
The rationale for choosing Ultimaster lies on the fact that this stent has actually 1 month CE label, which is very reassuring. Secondly, because we have seen from a Discovery 1 to 3 study very important and reassuring mechanistic information with respect to the capability of the stent to be completely covered already at 1 month at OFDI imaging. And finally, because in fact it has a specific and unique engineering component so that the drug and the polymer is only abluminally placed.
The Master DAPT trial is a really unique trial because it is one of the largest trials in high bleeding risk patients. It consists out of 4,300 patients.
Including actually Europe, Asia, America. All countries will be actually represented in this landmark investigation, and also the fact that unlike many other studies that are being planned and actually currently conducted, we are randomizing patients to either receive a very short DPT duration consisting of 1 month DPT only versus a more prolonged DPT duration, but still, let me say, still relatively short, consisting of a minimum of at least 3 or 6 months depending on whether the patient has or does not have a concomitant indication for oral anticoagulation, which of course is one of the HBR criteria. We don't want to include in the primary endpoint of the study the events which are happening the first month after PCI, which is we consider only noise and can only actually in a way bias the study results.
And it is unique because it also incorporates patients on oral anticoagulants or the novel, the NOACs as well. And those patients have not yet been investigated that much so far. So it's really going to be an interesting and very clinical relevant trial. The Master DAPT trial is currently enrolling, although we are still in a startup phase and we have more than 50% of our sites active.
With the current speed, and hopefully we will be able to increase even that speed, we think we can get the study completed by Q1 next year, meaning 2019, and finally have the results of the study in Q1 2020.